I'd like to begin by thanking the organizer for inviting me to give this talk. And first of all, here are my disclosures. The first point I want to make is that, luckily enough, the proportion of people living with HIV 50 years of age or older has been increasing since the arrival of combined antiretroviral therapy. And on this slide, you can see the proportion of men and women above 50 years of age in the COER, which is a collaboration of European cohorts. And also, to a lesser extent, the same is true in all regions of the world, as can be seen on this data from UNAIDS 2012, showing the proportion of people living with HIV above 50 years of age or older across the different regions of the world. During the remaining part of my talk, I will concentrate on only MI, cancer, and fracture because of time. And first of all, before looking at the data as to whether or not HIV-infected individuals have got higher risk of those conditions, just because of the aging effect, the number of those living with one or several of several non-AIDS events is going to increase over time just because of the aging. So if we now turn to MI, first, the earliest study published on the risk of MI in HIV-infected individuals were summarized in a meta-analysis published in 2012, showing that the risk of MI was higher in HIV-infected individuals compared to the general population. However, in those studies, it was impossible to adjust for all the traditional cardiovascular risk factors. So one is left to see whether it's an effect of HIV infection or to a higher prevalence of risk factor in the HIV-infected population. However, two more recent studies directly comparing an HIV-infected cohorts and a general population cohorts were able to adjust on the traditional risk factors and shown again a higher risk for HIV-infected individuals compared to the HIV-uninfected individuals, even after accounting for traditional cardiovascular risk factors. In terms of traditional risk factors, I show on this slide the results that we had in the French hospital database on HIV, in which we found that all traditional cardiovascular risk factors are associated with the risk in HIV-infected individuals. But I want to especially mention the two blue factors, the low HDL cholesterol associated with a higher risk, a higher level being associated with a lower risk, and the low BMI. Of course, it's well known that low HDL cholesterol is associated with a higher risk. However, in this particular case, it might be an effect of HIV infection, because it was well known prior to the CRT era that persons living with HIV have a lower HDL level. So this might be an effect of HIV, even though it's a traditional cardiovascular risk factor. In terms of BMI, in our study, we had very few patients with a very high BMI, but surprisingly found that the risk of MI was increased in those with a low BMI. And for instance, in the DID study, they also found that a low BMI is associated with a higher risk of stroke. And here again, although BMI is a known risk factor, it may be a distinct feature of HIV infection. If you remember the pre-CRT era and cachexia issue, it's obvious that HIV have a direct impact on fat tissues, and again, this may be an effect of HIV infection rather than the usual effect of a traditional risk factor. In this study, we also showed that a low CD4 nadir and a replicating variable load, as well as a high CD8 level, were all associated with a higher risk of MI. And again, this was recently confirmed in the most recent studies showing that a low CD4 nadir was associated with MI risk, although this is not consistently found in all studies. In terms of the effect of combined ART, I think there have been consistent evidence of an association of between cumulative exposure to older PI, I mean lopinavir, indinavir, etc., with a risk of MI, and this has been shown in several studies. In the only published study on the role of atazanavir, no association was found. However, the cumulative exposure was pretty short still. So I think the jury is still out for atazanavir, and there was no data available for darunavir, and there's also no data available on integrase inhibitors. And the results have been conflicting on NRTIs, and in particular on abacavir. If we now turn to non-AIDS-defining cancers, I present on this slide the result of a meta-analysis published in 2009 on the 4 most frequent non-AIDS-defining cancer in HIV-infected individuals: Hodgkin lymphoma, anus cancer, liver cancer, and lung cancer. And several studies were combined in this meta-analysis, and overall there was an increased risk of all 4 cancers. However, as shown on the last column, there was heterogeneity across studies. And this is because when you look at those studies, the relative risk may depend on the frequency of the risk factor in the general population, and it may depend as well on the frequency of the traditional risk factors in the HIV-infected population. For instance, for liver cancer, the relative risk will depend on the relative proportion of HBV and HCV co-infected individuals in HIV-infected population, and of the prevalence of HBV and HCV infection in the general population, which may well explain why the studies have got different results across countries. Just a note to say that consistently, the risk of breast and prostate cancer have been found to be lower in HIV-infected individuals, and this has been mainly linked with the hormonal effect of HIV infection. So in terms of risk factor for non-AIDS-defining cancer, we did a comprehensive study within the French hospital database on HIV on how to best model the relationship between the CD4 level and the risk of cancer. Should we consider the time spent to below a certain level, the current values, the value 1 year ago, the nadir? And we did the same also for viral load and treatment. And what we found for non-AIDS-defining cancer is that for Hodgkin, lung, and liver cancer, the lower the CD4 count, the higher the risk. And even at moderate immunodeficiency level, there's an increased risk. Interestingly, we found for anal cancer a different situation. We found that the cumulative time spent to below 200 was really associated with the risk. So we didn't find the same association for all the different cancer. And probably the physiopathology of the effect of HIV on those different conditions is not the same across all the different comorbidities, including the different type of cancer. So with this in mind, one may wonder what happens to people who, under CART, have restored a CD4 level above 500. Are they at increased risk? There's still few data on this topic published in the literature because of few cohorts which is large enough to get enough patient year of follow-up above 500, CD4 count above 500. But in a paper published in 2011, Silverberg and colleagues showed that both Hodgkin lymphoma and anal cancer are still much more frequent in HIV-infected individuals with CD4 above 500 compared to the general population. However, for lung and liver cancer, they didn't find any increased risk any longer. In recently published studies, we've shown the same result for Hodgkin lymphoma and lung cancer. However, for liver cancer, we still find a higher risk, and probably this is explained by the twice higher prevalence of co-infection with Hep B or Hep C in our sample compared to the one in Silverberg studies. Let's spend some moments on the role of smoking. Several studies have suggested that HIV infection is associated with lung cancer after adjusting for cigarette smoking. And in a recent study, a Danish study comparing an HIV-infected cohort to a general population cohort, they were able to disentangle the respective role of smoking and HIV. And they separated the various cancer in terms of smoking-related, virological cancer, and other cancer. And they've shown that the risk is increasing in HIV patients compared to the background population for both smoking-related cancer with an incidence rate ratio of 2.8 and virological cancer with an incidence rate ratio of 11.5, even after adjusting for sex, age, and smoking status. They also show that in the absence of smoking, the increased risk is confined to cancer related to viral infection, whereas the risk of other cancer, neither smoking-related nor virological, is not elevated and does not seem to be associated with immune deficiency. In terms of the effect of combined art, there is inconsistent evidence of a deleterious effect of PI or efavirenz, and I think in those studies there was not a full account of confounders, so it's difficult at the moment to conclude that there is a causal association. It's more likely explained by confounders. In terms of fractures and low bone mass density, several studies summarized on this slide have now shown an increased risk of fracture in HIV-infected individuals compared to the general population. Only one of the studies was negative. And the study in the US, which comprised only HIV-infected individuals, the one by Bedimo, shown that the fracture rate increased in the CRTR, which might be suggestive of an effect of treatment on the risk of fracture, but there's still few studies really looking at the role of the different treatment. There's much more data on BMD than on fracture for this matter. What were the risk factors for this condition in HIV-infected individuals? Again, low BMI, and it might be an effect of HIV infection again. African ethnicity and current smoking, traditional risk factors. HIV infection is independently associated with lower BMD at femoral neck, total hip, and lumbar spine. And I've cited this recent study in which there were both an HIV-infected and a non-HIV-infected cohorts, allowing to account for lifestyle factors as well as BMI. The effect of initiating CERT declined up to 4%, mainly in the first year. And the greater loss of bone mineral density with the use of tenofovir and to a less extent protease inhibitors. Finally, association of a low BMD with the risk of fracture has been recently shown. So it's likely that the low BMD is going to translate in higher risk of fracture in HIV-infected individuals. Let me finish by some words about whether or not there is an accelerated aging in HIV-infected patients. And my question is, are severe non-ACE events occurring at an earlier age in HIV-infected patients? This was initially studied by Schultz in a paper published in 2010. And of course, if you compare directly age at diagnosis between people with AIDS in this study and general population, you find a huge difference. However, there's a large difference in the age distribution between HIV-infected, on this slide on red, and the general population in blue. And these are data for France, but the same would be true in every country, of course, with a much lower proportion of older patients in HIV-infected populations compared to the general population. So when you adjust for this difference, from the 26 cancers that they studied, Shields and Old find out that only 8 had a significant difference, and the difference was much smaller, something like few years. And therefore, you don't have to speculate of an aging process. It may well be earlier diagnosis or earlier acquisition of the risk factor, which explains such a small difference. The same was true in the veteran studies for different conditions, such as lung cancer, MI, renal failure, etc. Very small difference. In these studies, it was mainly men. So we will come back to that later. We also looked at that for non-AIDS-defining cancer, and we didn't find big difference, the same result as the other authors, except for liver cancer. And we showed that the difference is really limited to patients with either Hep C or Hep B co-infection. And if we remind the data from prior to the HEART era, we all know that liver disease is progressing faster in HIV-infected individuals, and this is likely reflected there. Finally, for MI, we completed our published study from 2010 and look at the age and find the same result as the veteran study for men, but we find 5-year difference significant for women, illustrating the fact that, again, the physiopathology is not going to be necessarily the same across sex. So to conclude, even in the absence of an excess risk, the number of HIV-infected individuals with several events will increase because of aging, raising issues on the optimal management of multimorbidity and multi-drug exposures. The risk of age-associated severe non-AIDS events is higher in HIV-infected patients, independent of the risk factor and the prevalence of the risk factor. This is partly explained by higher prevalence, but not completely, as I said before. An effect of some heart has been shown for MI and bone disease. There is no such evidence for cancer. And the risk of some severe non-AIDS events for an individual with a CD4 cell count recovery under CERAP might not be elevated. And finally, the effect of HIV infection on age at diagnosis of common severe non-AIDS events is not uniform. It depends on comorbidities, on sex, and probably other risk factors. Let me finish by thanking my team and Hamid Justice and Paddy Malone, to whom I borrowed some ideas for this talk.